Thyroid cancer management. Q&A. Welcome to today's question and answer session on the management of thyroid cancer. Pause the video after each question to attempt answer. Let's begin. Epidemiology, pathology, and workup question. What are the 4 main types of thyroid cancer, in order of decreasing prevalence? Answer. The 4 principal types of thyroid cancer, in order of decreasing prevalence, are papillary thyroid carcinoma, follicular thyroid carcinoma, medullary thyroid carcinoma, and anaplastic thyroid carcinoma. Question. What is the most common type of thyroid cancer? Answer. The most common type of thyroid cancer is papillary thyroid carcinoma. Question. What is a Bethesda category and what is its purpose? Answer. The Bethesda category is a 6-tiered system for reporting results from thyroid fine needle aspiration cytology. It provides a standardized terminology and associated risk of malignancy to guide clinical management decisions. Question. What is the recommended management for a Bethesda Category 6 malignant nodule? Answer. Surgical intervention, typically thyroidectomy, is recommended for a Bethesda Category 6 nodule. Question. What is the recommended management for a Bethesda Category 5 suspicious for malignancy nodule? Answer. Surgical intervention, most often thyroidectomy, though diagnostic lobectomy may be considered as an initial step. Question. A patient has a Bethesda Category 3, atypia of undetermined significance nodule. What are the next steps? Answer. The recommended next steps include repeating the fine needle aspiration, often with molecular testing such as a Afirma gene sequencing classifier or Thyro the following to refine risk stratification. Some patients may proceed directly to diagnostic lobectomy. Question. What is the role of ultrasound in the workup of a thyroid nodule? Answer. Ultrasound is used to characterize the nodule size, composition, echogenicity, margins, and the presence of microcalcifications. It is also used to assess the whole thyroid gland and cervical lymph nodes. Question. What ultrasound features are suspicious for malignancy? Answer. Suspicious ultrasound features for malignancy include a taller than wide shape, irregular or spiculated margins, microcalcifications, marked hypochogonicity, and extrathyroidal extension. Question. When is a computed tomography scan with contrast used in the preoperative workup? Answer. A computed tomography scan with contrast is used for large, fixed, or substernal goiters to assess anatomy and extent, for evaluation of gross extrathyroidal extension or tracheal or esophageal invasion, and for assessment of nodal disease in areas difficult to visualize with ultrasound. Note that intravenous contrast delays radioactive iodine therapy. Question. What serum test is critical to check preoperatively for any thyroid surgery? Answer. Preoperative testing of serum calcium is essential to establish a baseline, and parathyroid hormone if available. Question. What serum marker is specific for medullary thyroid carcinoma? Answer. Calcitonin is specific for medullary thyroid carcinoma. Carcinoembryonic antigen is also often elevated. Question. A patient with multiple endocrine neoplasia type 2 syndrome presents with medullary thyroid carcinoma. What other pathologies must you screen for? Answer. Screening is required for pheochromocytoma with plasma metanephrines before any surgery, and for primary hyperparathyroidism. Question. What is the difference between sporadic and hereditary medullary thyroid carcinoma? Answer. Sporadic medullary thyroid carcinoma is most common and usually unilateral. Hereditary cases are associated with RET proto-oncogene mutations and are typically multifocal and bilateral. Question. What is a Hurtla cell neoplasm on cytology? Answer. Hurtla cell neoplasm is an oncocytic neoplasm, Bethesda Category 4. While often benign, the risk of malignancy is approximately 15 to 30%, and these tumors are less likely to take up radioactive iodine, making surgery the primary treatment. Question. What is a follicular neoplasm on cytology? Answer. Follicular neoplasm, Bethesda Category 4, cannot differentiate between follicular adenoma and follicular carcinoma on cytology alone. Diagnosis requires histologic evaluation for capsular or vascular invasion. Management is typically diagnostic lobectomy. Staging and prognosis. Question. What is the AJCCTNM staging system for thyroid cancer? Answer. The American Joint Committee on Cancer Tumor Node Metastasis staging system is site-specific, differing for papillary and follicular thyroid carcinomas, medullary thyroid carcinoma, and anaplastic thyroid carcinoma. It incorporates age, histology, tumor size, extrathyroidal extension, and distant metastasis. Question. A 40-year-old patient has a 3 cm papillary thyroid carcinoma with cervical lymph node metastases. N1A. What is the AJCC stage? Answer. For patients under 55 years old, any tumor or node status without distant metastasis is classified as stage 1. Only with distant metastasis is classified as stage 2. Question. A 65-year-old patient has a 2 cm papillary thyroid carcinoma without any metastases. What is the AJCC stage? Answer. Stage 1, corresponding to T1BN0M0 for patients 55 years old or older. Question. What is the significance of extrathyroidal extension? Answer. Extrathyroidal extension is a major prognostic factor that upstages a tumor to at least T3B for minimal extension or T4 for gross extension, and increases the risk of recurrence. It may necessitate more extensive surgery and radioactive iodine therapy. Question. What are the most common sites of distant metastasis for differentiated thyroid cancer? Answer. The lungs are the most common site, followed by the bones. Question. What is a low-risk patient according to the American Thyroid Association risk stratification system? Answer. A low-risk patient has no local or distant metastases. All macroscopic tumors are resected. There is no invasion of locoregional tissues, no aggressive histology, no vascular invasion, and no radioactive iodine. Avid metastatic disease outside the thyroid bed on the first post-treatment scan. Question. What is an intermediate risk patient? Answer. An intermediate risk patient has microscopic invasion of parathyroidal soft tissues, cervical lymph node metastases, aggressive histology, or vascular invasion. Question. What is a high-risk patient? Answer. High-risk patients have macroscopic gross extrathyroidal extension, incomplete tumor resection, distant metastases, or thyroglobulin levels suggestive of distant metastases. Surgical management, principles and decision-making. Question. What is the standard initial operation for a 2 cm papillary thyroid carcinoma without suspicious lymph nodes? Answer. The standard initial operation is total thyroidectomy. However, lobectomy is an acceptable alternative in selected low-risk patients according to the American Thyroid Association guidelines. Question. When is a thyroid lobectomy sufficient? Answer. Thyroid lobectomy is sufficient for low-risk patients with a single intrathyroidal tumor less than 4 cm, no history of radiation, no familial thyroid cancer, no clinically involved lymph nodes, and no distant metastases. Question. When is a total thyroidectomy absolutely indicated? Answer. Total thyroidectomy is absolutely indicated for tumors larger than 4 cm, gross extrathyroidal extension, bilateral nodules, clinically involved lymph nodes, distant metastases, history of radiation, or familial thyroid cancer. Question. What is a therapeutic central neck dissection? Answer. Therapeutic central neck dissection refers to the removal of lymph nodes in the central compartment or level 6 when there are clinically involved nodes. Question. What is a prophylactic central neck dissection? Answer. Prophylactic, or elective, central neck dissection is the removal of level 6 lymph nodes in a patient who presents with clinically negative nodes but high-risk features such as advanced tumor stage or aggressive histology. This is controversial but often performed for T3 and T4 tumors. Question. What are the boundaries of a central neck dissection? Level 6? Answer. The boundaries are the hyoid bone superiorly, suprasternal notch inferiorly, and between the carotid sheaths laterally. Question. What structures are at risk during a central neck dissection? Answer. The recurrent laryngeal nerves, parathyroid glands and their blood supply, thoracic duct on the left, and superior laryngeal nerves are at risk. Question. When is a lateral neck dissection indicated? Answer. Lateral neck dissection, encompassing levels 2 to 5, is indicated for clinically or biopsy-proven metastatic disease in the lateral compartments. Question. What are the levels included in a comprehensive lateral neck dissection for thyroid cancer? Answer. Levels 2A, 3, 4, and 5B are included in a comprehensive lateral neck dissection. Levels 2B and 5A are often included if the disease is extensive. Question. What nerve is at greatest risk during a level 2 dissection? Answer. The spinal accessory nerve, or cranial nerve 11, is at greatest risk. Question. What structure is at risk during a level 4 dissection? Answer. The phrenic nerve and the thoracic duct. on the left side, are at risk during a level 4 dissection. Question: what is the role of prophylactic lateral neck dissection? Answer: there is no role for prophylactic lateral neck dissection in thyroid cancer. Question: how do you manage a patient with a minimally invasive follicular carcinoma found on final pathology after a lobectomy? Answer: lobectomy is usually sufficient treatment since the risk of recurrence is very low. Completion thyroidectomy is not routinely recommended unless other high-risk features are present. Question: how do you manage a patient with a 1.5 cm papillary carcinoma found on final pathology after a lobectomy for a benign nodule? Answer: for this low-risk cancer, observation is often appropriate. Completion thyroidectomy may be considered if adverse features are present, such as positive margins, aggressive variant, or extrathyroidal extension, or if adjuvant radioactive iodine therapy is planned. Question: what is the surgical management for medullary thyroid carcinoma? Answer: surgical management involves total thyroidectomy with bilateral prophylactic central neck dissection due to the high rate of nodal metastasis. Therapeutic lateral neck dissection is performed for confirmed lateral disease. Question: what is the surgical management for anaplastic thyroid carcinoma? Answer: anaplastic thyroid carcinoma is often not surgically curable. Surgery is typically palliative, such as tracheostomy for airway obstruction, or debulking if there is a localized resectable component, usually followed by external beam radiotherapy and chemotherapy. The focus is often on establishing a diagnosis and securing the airway. Question: what is the role of intraoperative nerve monitoring? Answer: intraoperative nerve monitoring is an adjunct to visual identification of the recurrent laryngeal nerve, aiding in nerve identification, prognosticating postoperative function, and detecting nerve injury. Surgical complications. Question: what is the most common complication after thyroidectomy? Answer: transient hypocalcemia, resulting from parathyroid gland manipulation or devascularization, is the most common complication. Question: what are the signs and symptoms of hypocalcemia? Answer: symptoms include perioral numbness, paresthesias of fingers and toes, muscle cramps, Vostok sign, Trousseau sign, and in severe cases, tetany or seizures. Question: how do you manage transient hypocalcemia? Answer: management includes administration of oral calcium carbonate and calcitriol. Intravenous calcium gluconate is reserved for severe symptomatic cases. Question: what is the rate of permanent hypoparathyroidism? Answer: the rate of permanent hypoparathyroidism is less than 2 to 3% in high-volume centers. Question: how can you preserve parathyroid function during surgery? Answer: parathyroid function can be preserved by meticulous capsular dissection, identifying and preserving parathyroid glands with their vascular pedicle, and autotransplanting any gland that appears devascularized. Question: what is the rate of transient recurrent laryngeal nerve palsy? Answer: the rate of transient recurrent laryngeal nerve palsy is 3 to 5%. Question: what is the rate of permanent recurrent laryngeal nerve palsy? Answer: the rate of permanent recurrent laryngeal nerve palsy is 1 to 2%. Question: what is the first sign of a postoperative hematoma? Answer: airway obstruction, often preceded by respiratory distress, neck swelling, pain, or dysphagia, is the first sign and constitutes a surgical emergency. Question: how do you manage a postoperative hematoma? Answer: immediate bedside opening of the incision to decompress the airway is required, followed by a return to the operating room for exploration and control of bleeding. Question: what is the most common cause of bleeding after thyroidectomy? Answer: bleeding most commonly arises from a small artery or venous plexus, such as the middle thyroid vein or a branch of the inferior thyroid artery, less commonly from the superior thyroid artery pedicle. Adjuvant therapy and postoperative management. Question: what is the purpose of radioactive iodine ablation? Answer: radioactive iodine ablation destroys residual normal thyroid tissue and any microscopic residual differentiated thyroid cancer cells. Question: which thyroid cancers take up radioactive iodine? Answer: differentiated thyroid cancers, specifically papillary and follicular thyroid carcinoma, take up radioactive iodine. Hurtla cell, medullary, and anaplastic carcinomas do not. Question: what are the indications for radioactive iodine ablation? Answer: indications include high-risk features such as known distant metastases, gross extrathyroidal extension, incomplete resection, or a primary tumor greater than 4 cm. It is also considered for intermediate risk features such as lymph node metastases, vascular invasion, or aggressive histology. Question: what must be done before radioactive iodine therapy can be administered? Answer: the patient must be in a state of high thyroid stimulating hormone, typically greater than 30 milli-international units per liter, achieved by thyroid hormone withdrawal or with recombinant human thyroid stimulating hormone injections. Question: what is the role of external beam radiotherapy? Answer: external beam radiotherapy is utilized for locally advanced disease with unresectable gross extrathyroidal extension or positive margins, for palliation of bone metastases, and as primary treatment for anaplastic thyroid cancer. Question: what is the role of targeted therapy in thyroid cancer? Answer: targeted therapy, such as tyrosine kinase inhibitors, is used for advanced radioactive iodine refractory differentiated thyroid cancer and for advanced medullary thyroid carcinoma. Question: how is a patient monitored after total thyroidectomy for papillary thyroid carcinoma? Answer: monitoring is done through serial neck ultrasounds and measurement of serum thyroglobulin levels, as thyroglobulin is a tumor marker produced by differentiated thyroid tissue. An undetectable thyroglobulin on thyroid hormone suppression is a marker of no disease. Question: what does a rising thyroglobulin level indicate? Answer: a rising thyroglobulin level is highly suggestive of recurrence or persistent disease. Question: what is thyroglobulin antibody and why is it important? Answer: thyroglobulin antibodies can interfere with the thyroglobulin assay, making it unreliable. Trends in antibody levels themselves can serve as a surrogate tumor marker. Question: when is a diagnostic radioactive iodine scan used? Answer: a diagnostic radioactive iodine scan is used to localize recurrent or metastatic disease in patients with a positive thyroglobulin and negative ultrasound. Special scenarios and advanced topics. Question: how do you manage a patient with a small papillary microcarcinoma, less than 1 cm, found incidentally? Answer: active surveillance is an option for selected patients, involving serial ultrasounds. Surgery, typically lobectomy, is also a reasonable option. Question: what is a Berry-Picker metastasis? Answer: a Berry-Picker metastasis is a solitary, enlarged lymph node in the lateral neck arising from an occult papillary thyroid carcinoma. Question: what is the diffuse sclerosing variant of papillary thyroid carcinoma and why is it important? Answer: the diffuse sclerosing variant is an aggressive form often seen in younger patients, characterized by extensive lymphovascular invasion, dense sclerosis, and squamous metaplasia, with a high rate of lymph node and lung metastases. Question: what is a tall cell variant of papillary thyroid carcinoma? Answer: the tall cell variant is an aggressive form with a worse prognosis, characterized by cells that are 2 to 3 times as tall as they are wide, and is more common in older patients. Question: how do you manage a well-differentiated thyroid cancer presenting with a solitary bone metastasis? Answer: treatment involves total thyroidectomy, neck dissection if indicated, and radioactive iodine therapy. The solitary metastasis should be evaluated for surgical resection or external beam radiotherapy for local control and pain relief. Question: what is the role of ethanol ablation? Answer: ethanol ablation is used for managing small, recurrent cystic lymph nodes in the neck that are not amenable to surgery. Question: what is the role of thermal ablation, such as radiofrequency or laser? Answer: thermal ablation is an emerging technique for treating primary small low-risk tumors in patients who are poor surgical candidates and for recurrent nodal disease. Question: a patient has hoarseness preoperatively. What must you do? Answer: direct laryngoscopy must be performed to assess vocal cord mobility and document any pre-existing recurrent laryngeal nerve palsy, as this affects surgical planning and informed consent. Question: what is the significance of finding metastatic disease in a Delphian lymph node? Answer: metastasis in the Delphian node, which is prelaryngeal and located above the isthmus, is a predictor of central compartment lymph node involvement. Question: how do you manage a patient with a positive margin on final pathology? Answer: reoperation for completion resection should be strongly considered, especially for higher risk histologies or if radioactive iodine is unlikely to be effective. The decision is multidisciplinary. Question: what is the twist technique for the superior pedicle? Answer: the twist technique involves ligating the superior thyroid artery and vein by twisting the pedicle to bring the vessels into view. allowing for ligation close to the thyroid capsule to avoid injury to the external branch of the superior laryngeal nerve. Question: what is the function of the external branch of the superior laryngeal nerve? Answer: it innervates the cricothyroid muscle, which tenses the vocal cord. Injury results in an inability to project the voice, such as difficulty shouting or singing high notes. Question: how do you try to identify the parathyroid glands? Answer: parathyroid glands are identified by their tan or light brown color, flat oval shape, and distinct vascular pedicle. They are often located in predictable locations but can be anywhere. Question: what do you do if a parathyroid gland is excised or devascularized? Answer: the gland should be confirmed by frozen section, then minced and autotransplanted into a muscle bed, such as the sternocleidomastoid or brachioradialis. Question: how long does autotransplanted parathyroid tissue take to function? Answer: autotransplanted parathyroid tissue can take several weeks to months to function. Question: what is the role of intraoperative parathyroid hormone testing? Answer: intraoperative parathyroid hormone testing is not standard for thyroid cancer surgery but is crucial in surgery for primary hyperparathyroidism and may be used in concurrent parathyroidectomy cases. Question: what is a lateral aberrant thyroid? Answer: the term lateral aberrant thyroid is a misnomer. Thyroid tissue in the lateral neck almost always represents metastatic disease in a lymph node, not a developmental remnant. Question: what is a thyroglossal duct cyst carcinoma? Answer: a thyroglossal duct cyst carcinoma is a papillary carcinoma arising in a thyroglossal duct remnant. Treatment is the cyst-trunk procedure, which involves resection of the cyst, tract, and central portion of the hyoid bone. Question: how does pregnancy affect the management of thyroid cancer? Answer: surgery can be safely performed during the second trimester. Radioactive iodine is absolutely contraindicated during pregnancy and breastfeeding. Question: what is the most common cause of death in patients with differentiated thyroid cancer? Answer: although prognosis is generally excellent, the most common cause of cancer-specific death is from distant metastases, particularly in older patients with disease refractory to radioactive iodine. Medullary thyroid carcinoma specifics. Question: what genetic mutation is associated with hereditary medullary thyroid carcinoma? Answer: hereditary medullary thyroid carcinoma is associated with RET proto-oncogene mutations. Question: what is the most aggressive form of hereditary medullary thyroid carcinoma? Answer: multiple endocrine neoplasia type 2B is the most aggressive form. With early onset, prophylactic thyroidectomy is recommended within the first year of life. Question: when should a patient with newly diagnosed medullary thyroid carcinoma undergo genetic testing? Answer: all patients with medullary thyroid carcinoma should be offered genetic testing for RET mutations due to a high rate of heritability. Question: what is the goal of surgery for medullary thyroid carcinoma? Answer: the goal of surgery is biochemical cure, defined by normalization of postoperative calcitonin levels. Question: why is a central neck dissection always performed for medullary thyroid carcinoma? Answer: central neck dissection is always performed because the rate of central lymph node metastasis is very high, even with small tumors. Question: what is the role of radioactive iodine in medullary thyroid carcinoma? Answer: there is no role, as medullary thyroid carcinoma cells are derived from parafollicular C cells and do not take up iodine. Question: how is a patient with medullary thyroid carcinoma monitored postoperatively? Answer: monitoring is performed by serial measurement of serum calcitonin and carcinoembryonic antigen levels. The doubling time of these markers is highly prognostic. Anaplastic thyroid carcinoma specifics. Question: what is the typical presentation of anaplastic thyroid cancer? Answer: anaplastic thyroid cancer typically presents as a rapidly growing, hard, fixed neck mass in an older patient, often with symptoms of compression such as dyspnea, dysphagia, or hoarseness. Question: what is the prognosis of anaplastic thyroid cancer? Answer: the prognosis is poor, with median survival often measured in months even with aggressive treatment. Question: what is the first step in managing a patient with suspected anaplastic thyroid cancer? Answer: securing the airway is the first priority, which may require intubation or tracheostomy. Diagnosis is established by core needle biopsy. Question: what is the primary treatment modality for anaplastic thyroid cancer? Answer: treatment is multimodal and often involves debulking surgery if possible. combined with external beam radiotherapy and chemotherapy. Targeted therapy is an option for tumors with specific mutations. Lymph node mapping and advanced surgery. Question: what is a node-positive versus node-negative recurrence? Answer: node-positive recurrence refers to structural disease found in lymph nodes on imaging. Node-negative recurrence is a detectable thyroglobulin level with no identifiable source on imaging, indicating biochemical recurrence. Question: what is the role of positron emission tomography scan in thyroid cancer? Answer: positron emission tomography is used for locating disease in patients with radioactive iodine refractory differentiated thyroid cancer who have a positive thyroglobulin and negative radioactive iodine scan and ultrasound. Question: what is the important point about the recurrent laryngeal nerve's relationship to the inferior thyroid artery? Answer: the relationship is highly variable. The recurrent laryngeal nerve may be anterior, posterior, or between the branches of the inferior thyroid artery. The key is to identify the nerve low in the neck near the tracheoesophageal groove and trace it superiorly. Question: what is the most common site of recurrence for papillary thyroid cancer? Answer: cervical lymph nodes are the most common site of recurrence. Question: how do you manage a patient with a solitary, well-defined central compartment recurrence 2 years after initial surgery? Answer: reoperation with compartment-oriented dissection, or central neck re-exploration, is the standard of care. Question: why is reoperation in the central neck more dangerous? Answer: the presence of scar tissue and loss of normal tissue planes increases the risk of injury to the recurrent laryngeal nerve and parathyroid glands. Question: what is the role of minimally invasive techniques, such as robotic or endoscopic surgery, in thyroid cancer? Answer: minimally invasive techniques are alternative approaches for selected patients with low-risk disease, primarily for cosmetic reasons. They are not the standard open approach and require significant expertise. Question: when is sternotomy or thoracoscopy required for thyroid cancer? Answer: sternotomy or thoracoscopy is required for a substernal goiter that cannot be delivered into the neck or for resection of metastatic disease in the anterior mediastinum. Question: what is the most important principle in the surgical management of thyroid cancer? Answer: the most important principle is that the goal of the first operation provides the best chance for cure. It should be performed by a high-volume endocrine surgeon to minimize complications and ensure appropriate oncologic resection. Incomplete surgery or surgery with complications makes future treatment much more difficult. Thanks for tuning in. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.